appropriately, I believe. We'll see. Okay, I saw one name that said one more joke. How about I give you two more jokes? What do you call a cow with no legs? Ground beef, yes. What do you call a cow with only two legs? Lean beef. The cow with a twitch? I don't know. Beef jerky is pretty good. Yep. Nice. Nice. That would have been good during the neuro section, the procedures. All right. Let us get started. Anyone want to guess what the random trivia will be for this time? I decided to go extra nerdy this time. Nope. Didn't do that. Would have been a good one. I actually decided to go with the elements, the periodic table. So can you recognize which elements go with which chemical symbol? So let's see who our chemistry nerds are. All right, let's begin. I'll announce that beforehand because I have no idea when they're going to show up. So, all right, how would you adjust the dose of simvastatin for a patient taking ritonavir? Increase the dose, stop the drug, decrease the dose, or use the same dose? There's two correct answers. All right. Yes, absolutely. So again, ritonavir. What's the interaction we're looking at here? CYP3 for induction, inhibition, inhibition. Absolutely. So this is CYP3 inhibitor, right? Because why do we use ritonavir? Yeah, so we can boost our other antiviral drugs, particularly the protease inhibitors, right? So if you see like lopinavir, ritonavir, darunavir, and ritonavir, you guys for the prescriptions, you look up the currently recommended regimens. You'll see that like darunavir, ritonavir is a commonly recommended one, right? So we use that as a booster by acting as a 3A4 inhibitor. So knowing the simvastatin is a CYP3A4 substrate, what would you do to the dose? You could decrease it to try to combat that, or a valid option would be to stop the drug altogether and then start something different, right? So you could start maybe a statin that did not interact there. Anyone know any good options there? Yeah, Crestor or rosuvastatin's good. Like atorvastatin would be an okay option as well. Either of those would be fine because you mitigate that they get mainly metabolized by non-CYP mediated means. So that would be good options as well, right? So again, knowing your drug selection based on these drug interactions can be a really important aspect here. Because again, when you're on these protease inhibitors, what happens to your lipids? They tend to worsen, if anything, right? So you can see more risk for like diabetes, hypertension, hyperlipidemia. They tend to worsen over time. So again, this is something to definitely be concerned about because they're going to be at risk for more cardiac disease because they're getting older and living for longer with HIV. Good. Okay. This is wrong. Be away soon enough. All right. Which of the following only work when the HIV virus expresses the CCR5 receptor? Atazanavir, Elvitegravir, Nalfinavir, or Maraviroc? So going back to the mechanism for the drugs. It's good to keep separate in your mind, right? Because again, we're deciding what regimens we want to use. We want to know how each of the drugs are working. I wish I had binoculars for you guys. I feel bad. The ring might not be big enough. All right, and again, this is tough because, again, a lot of Indonvir, it's very difficult to delineate which ones fall into which categories there. So what kind of drug is atazanavir? Protease inhibitor. How about nalfinavir? Protease inhibitor. How about elvitegravir? It's an integrase inhibitor, right? So it's like you know, a different category, but again, another one of those good sort of active drugs we can use for our recommended regimens there. And then maraviroc or Cellzentry is going to be one of the ones that inhibits that CCR5 sort of binding there. So again, you have to test for that. You have to test for that in the virus, make sure it's actually expressing it. If it doesn't, then it's not going to be useful for you. Because again, it can change over time. It may be present at first, and then you may lose that over time as the virus mutates. And again, what does that CCR5 do for us by inhibiting that? Yeah, so basically it's going to block the human receptors, but then what does that do for us? How does that? Doesn't inhibit replication directly, prevents the virus from getting it, right? Because remember, it looks for its co-receptors. It looks for that CD4, right? That's why it infects those T cells predominantly. But it's also looking for those other co-receptors. CCR5 is one of those, and when it binds to that, it says, hey, let's go ahead and get into this particular cell. If you can block that, then potentially you can inhibit that entry from occurring there, right? It's not like a fusion inhibitor. It's not integrase inhibitor or anything like that. It's just preventing from getting into the cell in the first place. That's again, and would that be a recommended drug for kind of initial start for these patients? No, right? So again, really what's our three main classes of drugs we're going to use for those regimens? So usually 2 NRTIs. You could just use 2 NRTIs plus an NNRTI. That'd be fine. What else? Protease inhibitor or an integrase inhibitor, right? Any of those would be fine. Regimens, you always want to have that 2 NRTI backbone for those regimens there. Maraviroc may be used in certain cases, especially if the virus has been tested and it actually still expresses that receptor there. Good. All right. The meat tornado. I feel like I've been described as that at least one point in my life, but usually I go to Fogo de Chao or something. Yeah. All right, what's the chemical symbol for mercury? Is it AU, AG, FR, HG? Which could it be? So AU is red, FR is blue, AG is gold, and HG is green. AG is not actually gold, but it's a gold color, I should say. Very good. Yeah, actually, absolutely. So, and again, when you see like blood pressure, you just like millimeters of mercury, so mmHg. So that one's kind of an easy one. What's AU? AU is gold. Yep. AG, silver. Absolutely. Then FR. Francium. I had a periodic table in front of me. I was looking at all of these at the time. So yes, francium was what that one is. Okay. Very good. Get no points for that. What is the chemical symbol for lead? Is it P is in red? PT is blue. Yellow is PD, or green is PB. There's no L's here. What's up with that? PB is the correct answer here, right? So when you say PB and J, make sure no one's putting lead on your sandwich. Otherwise, that could be very bad. P is what? Phosphorus. Yep. PT. Platinum. PD. Palladium. And then PB is lead. Which country could attribute its fall to due to lead poisoning? Rome, absolutely, yeah. So actually, they had like lead-lined pots and things like that. They were leaching lead to, and that was it's a very potent neurotoxin, so it's thought to lead to the decline of Rome. There's probably some other reason for that, but I like to attribute it just to lead because I'm a toxic guy. So anyway, good job. Up next, naloxone is to morphine as blank is to diazepam. So reliving our SAT moments here. It would be flumazenil, physostigmine, atropine, or ethanol. What do we think? All right, yes, flumazenil or ramazicon would be the drug that would antagonize the benzodiazepines. Now, if I put like phenobarb on here, could I use flumazenil? No, it only works for benzodiazepines. It only works for, Xanax or Ativan or Valium or any of those. It only works for those, right? Physostigmine is good for what? Physostigmine is an acetylcholinesterase inhibitor, a reversible one, which would affect anticholinergics, right? So if someone had taken Jimson weed, or if they had overdose on Benadryl or something like that, an anticholinergic, physostigmine would help to reverse those effects by increasing acetylcholine levels, right? How about atropine? What would that be good for? Yeah, for cholinergic toxidrome, atropine would be good for that. So if you had like an organophosphate poisoning or something, an insecticide poisoning, that could be one you could use atropine to help reverse nicotinic effects or muscarinic effects. Muscarinic only. Atropine only works on the muscarinic stuff, so it would help to dry out the patient. So again, their lung secretions would be inhibited. They would hopefully not be defecating and urinating everywhere. It would kind of help to dry all that out. What does atropine do to heart rate? Should increase, right? So again, if the patient's vaguely down, you can try to perk them back up. How about ethanol? This is actually in the rest of that CMS lecture, which I'll be recording shortly. Caffeine? No. Although caffeine and ethanol was a bit of a problem. Anyone know what product popularized caffeine and ethanol? 4 Loko. Should call like 6 Loko based on some of the case reports we saw with that one. Yeah, that was actually pretty bad. Hopefully no one experienced the 4 Loko craze. But yeah, mixing caffeine and ethanol was not great because 4 Loko actually had pretty high alcohol content, and patients would get pretty drunk. And normally they would fall asleep from being so drunk. Instead, they were kept awake by the caffeine. And normally ethanol makes you make better decisions. Typically, no. I don't know if I've ever seen anyone say, man, I made some great decisions last night. But anyway, they're making very poor decisions, like getting into cars and doing all sorts of bad stuff. So the government said take it out, and they took it out before they got removed from the market. But ethanol itself can actually be an antidote to other toxic alcohols. So if you had something like an ethylene glycol ingestion from like a radiator fluid, or methanol ingestion like windshield wiper fluid, that is actually an inhibitor of those substances there. I'll talk about that in the other lecture, so just know that it still is an antidote. We don't use it too frequently anymore, though. Anywho. All right, oops. Next. Which of the following areas can you safely inject lidocaine? This is a point I actually forgot to mention in the lecture, so I'll clarify this in a second here, but which of these areas are okay to inject lidocaine? I'm glad I included this. I forgot to mention on the lecture, but I won't clarify it here. Any of these areas are safe to inject lidocaine into. The point I forgot to mention during the lecture is when you combine a vasoconstrictor plus lidocaine, that limits where you can inject the drug to. Where can you not inject lidocaine plus epinephrine into? Those places. Why is that? Because of vasoconstriction. Those are terminal areas for blood flow. So if you inhibit that, you can end up seeing tissue hypoperfusion with oxygen. You can end up seeing tissue necrosis that can occur. Again, it's unlikely to be clinically relevant in a lot of cases, but as a general rule of thumb, you do not inject lidocaine with epi into the fingers, the nose, the toes, or they say the hose is the other one too. I didn't make up the mnemonic, but that's how I remember it. So again, those are places you do not want to inject lidocaine with epinephrine, but lidocaine by itself is totally fine, right? Okay. A patient with an allergy to lidocaine could safely receive which drug? See, prilocaine, bupivacaine, procaine, or mepivacaine. So they have a true anaphylactic allergy to lidocaine. Say, what can I get? You can tell just by looking at the names of the drugs. Like one person always wait until the very last second. Just not sure right to the very end. Okay. Yeah, so procaine would be the correct answer here. So what am I looking for? Yeah, the eyes, right? So the eyes have it, I should say. So again, comparing the amides versus the ester anesthetics here. So if it has an I before the cane, you know it's an amide. Lidocaine, having an I there, you know it's an amide anesthetic. So I would not want to give another amide anesthetic. So I'd avoid things like prilocaine. I'd avoid things like bupivacaine. I'd avoid things like bupivacaine. However, procaine, you know, is going to be an ester because it doesn't have the I before the name. It's very nice they did that for you already, so you can look at a drug and know whether or not it's going to cross-react potentially. So procaine would be safe in that case. Benzocaine would be safe in that case. Cocaine would be safe in that case if you're so inclined. But those are the things you're going to be looking for with anesthetic allergies. Good. Up next. Which of the following signs and symptoms is consistent with a cholinergic poisoning? Be bradycardia, urinary retention, mydriasis, or constipation. Excuse me. Right, so bradycardia, actually this is probably technically not 100% correct. I will clarify this in a second. The bradycardia, though, is certainly consistent with the cholinergic poisoning, right? So you'd expect to have more activity on those muscarinic receptors, and you would say definitely see vagal activity increase. You see bradycardia. Urinary retention, would you expect to see that? Oh, not part of the dumbbells. Would you expect to see constipation? You know, you expect to see diarrhea, if anything, right? Because, again, you're waking up the GI tract and the urinary tract. Mydriasis you'd normally not expect due to muscarinic effects. I apologize for the 12 people who picked mydriasis. Because when do you get mydriasis? The nicotinic effects. You may see that very early on. You see them, remember the days of the week I mentioned, or that mnemonic there. However, that usually gets overcome by the muscarinic effects, and so that will cause meiosis typically. Okay. So again, I apologize to the 12 of you who are technically correct. If I can go back in time and change it, it's fine, but I will give you one free answer for the test at the end of the lecture, along with the winner of the proceedings here. So just sit on that one for a little bit. Anywho, that makes sense? Okay. Sulfamethoxazole, trimethoprim, or Bactrim is used to treat which opportunistic infection? Mycobacterium avium complex, cytomegalovirus, oropharyngeal candidiasis, or PCP pneumonia. All right, PCP pneumonia is correct. So which one's kind of rule out immediately? Cytomegalovirus is obviously a virus, so that would not be good for Bactrim. How about, what else can I rule out? Yeah, the candidiasis, because that's what? It's a fungal infection, so that wouldn't be good either, right? The Mycobacterium avium complex is going to be what type of bacteria? Think like mycoplasma. It's more of like a so it's also mycoplasma. It's like TB. Think about it as more of like an atypical sort of bug there. So that would not be a good option for Bactrim. PCP pneumonia, though, is going to be one of our main drugs we're using as prophylaxis and also for treatment of that. MAC is usually treated with things like clarithromycin, azithromycin. Again, you don't see as frequently because usually patients have to be much more immunocompromised, like usually the CD4 count like getting below 50 before you start prophylaxing for that. PCP is one of the more common ones you see, though, because that is below 200 is where you start to prophylax for that. We see that a lot in chemo patients. We see this a lot in AIDS patients, where we're going to be giving Bactrim for prevention, then also for treatment. Okay. All right. Neurosyphilis would be most appropriately treated with which medication? So ceftriaxone, benzathine penicillin G, aqueous penicillin G, or azithromycin? The correct answer is actually the aqueous penicillin G. We'll talk about why that is in a second. So normally you think syphilis, drug of choice? Penicillin, absolutely. So again, even though been using it for years and years and years, still retains pretty good efficacy against syphilis. So again, penicillin is probably going to be one of your go-to drugs there. Good. Bicillin, though, how is that usually administered? Benzathine penicillin G. It's an IM shot, right? That's going to be good for a normal course of syphilis where you just need to give them a one-time shot and they're done. However, when you have something more invasive like a neurosyphilis, is where it requires more intensive therapy. You're going to require more IV therapy. So this is where you bring them in, typically go to the ICU, and they're going to be on continuous aqueous penicillin G. That's the IV form they will be getting consistently. Okay, so that's kind of, again, some of the differentiators there between what type of syphilis you're treating. It will dictate which sort of penicillin you're going to use there. Make sense? Right. Which of the following would identify a venomous snake in Florida? Red on black coloring, a rounded head, a striped banding pattern, or elliptical pupils? Remember also the anal plates are a great place to check a snake to see if it's poisonous or not. Right, the elliptical pupils are a good way to tell if a snake is venomous here in Florida, right? So that would delineate which type of venomous snake. Pit viper or Elapidae, coral snake? Pit vipers, right? Pit vipers are going to have the elliptical pupils. They're going to have, what else can identify them? If they have a rattle, certainly. If there's rattling at you, chances are just stay away from it, right? May not always have that there, but certainly may. Right, so a single row of anal plates may delineate a venomous snake versus a double row would be a non-venomous snake. What else? Yeah, so triangle-shaped head is the big thing right there. So a triangle-shaped head would be a good indicator there. What else? Heat-sensing pits. So if it kind of looks like nostrils, but they'll be kind of more lateral to that. Heat-sensing pits. Again, if you're getting that close, you should reevaluate your life decisions. Anything else? Ginormous fangs could be a good sign, right? The thing is rearing back at you and fangs are out. That's a good sign. That's also a venomous snake. So again, those are things you want to be looking for. Typically for the pit vipers. How about the coral snakes? How would you identify that? Red on yellow, kill a fellow, right? So if you see red on yellow banding pattern, it's in the body of the snake. It's not the head or the tail, because that starts to get a little, more variable there. Typically they have a black head, but they do have the rounded head. They do have more of the circular pupils. However, that red on yellow pattern is what we're going to use to identify the eastern coral snake here in Florida. If you go to South America, if you go to Asia, you're going to find that's not going to be the case there. You can't use those same color rules here. But and again, if someone had, say, some sort of Mexican coral snake get loose from their private reserve, obviously that would go by the wayside as well. However, and that can happen. Stuff like that happens. People let their pythons out all the time, especially like in South Florida. I know it's kind of a big problem. So just be aware. But for the most part, for venomous snakes that are indigenous to Florida, that's what you're looking for. Good. Someone get confused for Brittany quite frequently? This is not Brit Pet. I was just curious. It's probably accurate, but yeah. Acute kidney injury caused by lisinopril will be classified as intrinsic, postrenal, or pre-renal. So lisinopril, ACE inhibitor. How is that going to be affecting us? Interesting. It's actually going to be a pre-renal sort of kidney injury. Why do you think that is? It's affecting blood flow going to the kidneys directly, right? Because it's affecting which side of the flow? The efferent arterioles, right? The ones that are heading out from the glomerulus. What is it doing there? Vasodilating, right? Because you're decreasing Ang2 productions, they're going to be decreasing that vasoconstrictive effect there, and that's going to decrease that backflow pressure on the glomerulus. So your GFR, the actual filtration rate, tends to take a hit for those patients who are really kind of dependent on that Ang2 to keep that pressure up, right? So that would be more of a pre-renal issue, to where the kidneys are just not being as perfused as well, right? That's the main thing you're going to see with that. Post-renal is not really causing any obstruction, and intrinsic, probably unlikely to cause any actual intrinsic damage to the cells themselves. More likely, you're going to see the pre-renal issues there. Okay. All right. What is a strategy to prevent acute kidney injury for a patient on amikacin for pneumonia? Place the patient on maintenance fluids, ensure the trough is above 2 mics per ml, add Lasix to their medication regimen, or use Q6-hour dosing. What are some strategies we could use if we had to give amikacin, an aminoglycoside? How can we get away with avoiding a kidney injury? This is a concentration-dependent antibiotic. Good for gram-negatives. If that helps with this question. What do we normally use amikacin to cover? The pneumonia. The gram-negatives, more specifically, what can it cover? Pseudomonas. That's the big thing we worry about. Yeah. Yes, keep it simple, right? So just making sure the patient's hydrated, right? Making sure they have good amount of fluids on board. You know, things can happen when patients are transferring from, say, different levels of care. Oftentimes, you know, you have to do med recs, any sort of change in level of care for those patients. You know, make sure they have their fluids on board if it's appropriate for them. You know, making sure the trough is above a certain level, not usually going to be good for that, because typically with a concentration drug like that, you want to get really high peaks, and then you can let the level drop down to 0 because you have that post-antibiotic effect. So keeping the trough high is actually one of the things that can predispose you to having kidney injury. If you can't clear the drug effectively, keeping too much around, that's going to cause kidney injuries. That's not good. Adding Lasix, why would that be not a good strategy? Yeah, it's harsh on the kidneys, but also it's going to dehydrate your patient, right? And so we know that by decreasing perfusion to the kidneys, by decreasing intravascular volume, not going to be good, right? So that would not be a good idea. And then use Q6-hour dosing. We don't recommend that anymore. We used to use Q8-hour dosing quite frequently for these drugs. Now, because we understand that you know, it's a concentration-dependent drug, we can use Q24-hour dosing. So we give a really big dose one time a day. The levels get very high, kill off the bugs, and then as the levels drop, it should be negative by the time you get that next dose, right? So 24-hour dosing is one way we can get around that. In some cases, patients will get Q36, Q48-hour dosing, depending on what their renal function looks like. Make sense? All right. Just noticing the little rivalry here between not Brit Pet and Brit Pet. Some sort of Highlander-esque showdown may occur. There can only be one. Who will it be? All right. Which opioid may cause chest wall rigidity when given too quickly? I know you're just like, yeah, that's right. You're like, don't humor me. It's fine. Our references go over many heads. All right. So anyway, which opioid is no good? Because if you give it too quickly, chest wall rigidity may ensue. Hydromorphone, heroin, morphine, fentanyl. Keep in mind, this is different than the respiratory depression that is ubiquitous amongst opioids. Yes, fentanyl is the correct one, right? Because this comes from the surgery section, right? You know, none of the other ones really do this, and so we like to slow down our infusions. That helps to limit this from occurring. And again, if you had to reverse that effect, you'd have to give naloxone, right? That can actually help to reverse it. But if I'm giving the fentanyl in the first place, chances are they are in pain, and do I want to necessarily reverse those effects for the patient? Not typically, right? I give a different opioid in that case, but again, that's still being antagonized by the naloxone, so it's no good. You just avoid it in the first place. It's always going to be good for those patients. Okay. What is the chemical symbol for barium? Why did I put that picture? Yep. We'll use that for barium for GI studies. So either swallow studies, we can do barium enemas, things like that. Is it BI, BE, BA, or B? Actually, BA. That's a little bit easier one. Now, the barium that we administer through the GI tract for imaging, does that get absorbed at all? Actually, it does not. That's a good thing. Usually, there's going to be insoluble barium that is, radiopaque. You can see it when you do imaging studies in the GI tract. However, it's good that it's not absorbed systemically because you can see some issues with that. Namely, barium likes to bind to potassium. So we've actually had cases where patients have gotten a soluble form of barium that gets absorbed, and they find really profound hypokalemia, and patients have died from that. So you have to be careful with that stuff. But yeah, the barium we have is insoluble; it does not get absorbed. That's why it's important if you're doing certain studies, you may have to give IV plus PO contrast, right? So it's usually like a barium product plus some sort of IV, maybe iodine-based contrast agent there, because again they don't work for both in those cases. BI is bismuth. Yep. BE, beryllium. Hopefully no one's looked up the periodic table. That'll be very, very inappropriate. How about B? Boron. Yes, boron would be the correct answer to that one. Perfect. All right. A patient with a history of malignant hyperthermia can safely receive which paralytic? Could they receive vecuronium, cisatracurium, succinylcholine, or rocuronium? Bless you. One last holdout. Are there teams going? Because I know there's 63 of you. I'm trying to figure out what the numbers are. Some people just don't want to play. Everyone should participate. There's no trophies here, but everyone should participate. Yeah, there's 3 correct answers here, right? So the main paralytic you think of with malignant hyperthermia is succinylcholine, right? Another reason why sucks, as some people would say. What else can cause malignant hyperthermia? The halogen, right? So what are some examples? Isoflurane, desflurane, sevoflurane. Yeah, any of those could be potentially causing that as well. So just remember those are the main drugs. What is our treatment for that going to be? Dantrolene, right? Dantrolene plus what? For the acidosis? Sodium bicarb. For the heat, the hyperthermia? Cool fluids, cooling blankets, ice packs, anything like that are going to be good to help bring that temperature back down for the patient. But dantrolene is the most important piece of that. Good. All right. Up next, which of the following signs or symptoms is consistent with a sympathomimetic poisoning? Constipation, bradycardia, mydriasis, or urinary retention? So if someone came and overdosed on cocaine or say some amphetamines. Perhaps they took an extra Adderall. So I really got to study for this test. None of you would ever do that. That's more of an undergrad issue, but. I hope it's an undergrad issue. I hope it's not a professional school issue. We should do that, P-test you guys before every test. Just hopped up on amphetamines, see if you guys do better than the other students. No. Just kidding, we would never do that. All right, so which would be consistent with the sympathomimetic? So you're thinking stimulants, you're thinking things that are increasing your sympathetic nervous system outflow. So mydriasis would certainly be expected here, right? So coming to that very wide open pupils, that is something you would expect to see with that. Why not constipation? Don't slow down the GI tract. If anything, you may have normo to hyperactive bowel sounds in those cases there. Bradycardia, would you expect to see that? No, tachycardia would be pretty ubiquitous amongst those patients, and then urinary retention, typically not, right? They can pee fine. They're not going to be incontinent like you would see with a cholinergic, but normally they're not going to have any issues with urinary retention in those cases there, right? But certainly mydriasis is definitely expected. Hypertension, tachycardia, diaphoresis, anxiety, agitation, hallucinations, those are things you expect to see on a patient who's been exposed to a sympathomimetic. Okay. A patient with a sodium of 110 milliequivalents per liter is seizing. Which of the following jokes is most which of the following fluids is most appropriate? I was already thinking ahead to the joke I was going to tell. Which of the fluids would be most appropriate? So you have D5W, 3% sodium chloride, 0.9% sodium chloride, or 0.45% sodium chloride. I was going to ask if you guys want to hear a joke about sodium. Nah. Hear one about potassium? Okay. I'm sure I've used that one before, so. You guys know what you do with the dead chemist? Bury him. If you can't cure him, you have to bury him. Yeah. All right, so yes, 3% sodium chloride would actually be best. So again, this is going to be for a patient who's actively seizing. We know we need to get that sodium up immediately, right? So that's where we're going to use hypertonic saline because that's the most quick way we can get the most amount of sodium into that patient, typically, right? D5 would not be appropriate because no sodium. It would only lower sodium even further. That would be a bad show. 0.9% sodium chloride. That could replace it, right? Because again, that's going to be more sodium because normally 0.9% has 154 milliequivalents per liter of sodium. If the sodium is 110, by giving normal saline, that would definitely increase it. However, it's going to take time. That's a lot of fluid I'd have to give to the patient, so not appropriate in this kind of acute sort of setting. 0.45% is only around 74, I'm trying to think what it is, 78, whatever it is, milliequivalents per liter. Again, that's lower than what this patient is at. Again, we'd be replacing him, right? Not appropriate. However, 3% saline is going to be perfect in this case. If the patient was say once you got them out of the seizing sort of aspect and you say they were hypovolemic, normal saline is a great drug to use in those cases. And again, what's your limit to how much you want to correct those patients? 12 milliequivalents in 24 hours, right? So again, I may do that initial 6 or so, or maybe 8 potentially, to stop the patient from seizing. But once I'm at that point, then I need to figure out how much I need to give the rest of that 24-hour period, not to exceed 12, because what's my risk? Yes, so central pontine demyelination, yes, that's no good, right? So again, 12 milliequivalents per 24 hours is going to be the limit there. All right. So close. I mean, look at this, just neck and neck. Not Brit Pet and Brit Pet. It's a showdown for the ages, I'm just saying. Anyway. Acute kidney injury from cisplatin would be categorized as postrenal, intrinsic, or pre-renal. It would have made more sense to put those in order buttons and randomize. So, for cisplatin we use for cancer, right? It's an alkylating agent. Yeah, this would be more of an intrinsic sort of kidney injury, right? So it's not doing anything to affect kidney blood flow. It's not doing anything to obstruct kidney blood flow or urine flow. So this would definitely be an intrinsic, actual direct damage being done to those renal tubules. Bless you. Does that make sense? How would I combat this? You still do it very similar to how we do it for a lot of pre-renal kidney injuries, is you just give them a ton of fluids. So to make sure they are going to be replete with fluids, so that way urine flow is very good. It's going to try to get that stuff out in a pretty decent manner there. So again, avoid dehydration if you can for these patients. Okay. Good. Which of the following would worsen hyperphosphatemia in a patient with renal osteodystrophy? Aluminum hydroxide, calcium acetate, calcitriol, or cinacalcet. What would cause worsened hyperphosphatemia in a patient with renal osteodystrophy? Interesting. So we're worsening hyperphosphatemia. So perhaps a drug called Foslo would actually lower phosphate. So again, be aware of what the drugs are going to be indicated for. So aluminum hydroxide, what is that going to do for us? Bind up phosphate, right, in the GI tract specifically, so you need to take it around mealtime. Calcium acetate, similarly, would bind up phosphate in the GI tract. You know, calcium carbonate would have been another option here that could lower phosphate. How about cinecalcet? What's that doing? It's actually sensitizing the parathyroid to the effects of the vitamin D that's already floating around, essentially. So try to limit the activity of the parathyroid. So again, that would not necessarily worsen hyperphosphatemia. If anything, it could maybe improve it in some cases. How about the calcitriol? What is calcitriol? Activated vitamin D, right? So if you have patients with poor kidneys, this is what you're going to give them. But why would that worsen hyperphosphatemia? It's going to stimulate, you know, reabsorption of phosphate from the kidneys, like a whole host of things. So again, this would not be a good thing if you had a patient who's already pretty bad hyperphosphatemia, or you give it in conjunction with something like cevilemer or lanthanum or calcium acetate or any of these options that can help to lower phosphate. Because again, they still need that vitamin D because they still need to have that effect to inhibit the parathyroid. But in those cases, you may get away with using something like cinecalcet instead. So again, just depends on your patient. All right. Up next, which drug would finish this HIV regimen? We have zidovudine, emtricitabine, and what else could we use? Raltegravir, etravirine, abacavir, or lopinavir, ritonavir. All right, so 3 correct answers here. So I mentioned, so with zidovudine and emtricitabine, what do I have 2 of already? 2 NRTIs, right? So this is already my backbone here. So I need to add 1 other drug with a complementary mechanism. So I could use something like raltegravir, because that's what? It's an integrase inhibitor. Good. I could use lopinavir, ritonavir, because that's a protease inhibitor combination, right? Again, ritonavir being the booster in that case, boosting lopinavir's levels. Etravirine. Yeah, it's an NNRTI we could be using as another complementary component there. How about abacavir? It's another NRTI. You don't want 3 NRTIs. That would not be an appropriate regimen. You need to have 2 NRTIs and usually a PI or an NNRTI or an integrase inhibitor. Make sense? Okay. All right. What is the chemical symbol for copper? Cu, C, Cr, or Ce? Do you know what pennies are largely made out of nowadays? Not copper. Some nickel. Some zinc. A lot of zinc as well. If you think about it, you'll understand. Ooh. All right. I really wish this was the last one so I could say see you guys later, but that's not the case. So, anywho, yeah, Cu is copper. How about what's C? Carbon. Good. Cr. Chromium. Yep. And Ce? Cesium. What is selenium? S. Yeah, selenium is just S. Ce is cesium. Yep. You guys are bigger chemistry nerds than I thought, so I'm very proud of you all. All right, which sedative agent could be used for induction prior to surgery? So induction of sleep prior to surgery. propofol would be good. So desflurane is what? It's an inhalational anesthetic, right? Remember, those don't have as good a fast onset as you would see with like an IV agent, so those are not good for induction necessarily. How about sevoflurane? Same issue, right? How about cisatracurium? It's a paralay, right? So that's not going to be good for inducing sleep in your patients. It'd be very bad form if you gave them that before they got a sedative agent. So propofol or dipravan is going to be your agent of choice here. Make sense? Fentanyl will be fine here. Remifentanil, any sort of sedative agent will be totally fine there as long as it's an IV product, right? Good. All right. Which of the following would not be indicated for a bite from the following snake? So if you saw this guy here coming to bite you, which of the following would not be indicated? Crofab, rabies vaccine, North American coral snake antivenom, or tetanus vaccine? You know what kind of snake that is? That would be an eastern diamondback, yep. Those bites are quite difficult to treat, I will say, from a antivenom standpoint. It requires a lot. It depends, but yeah, generally you'll find that they will cover that. Because again, if you don't treat your patient, then they might die. Right? Yeah, you don't want them to die typically. So yeah, generally, but again, it may depend on the type of insurance. I don't know if there's any. I'm sure they have like a certain diagnosis code that's assigned to that particular thing, and you get reimbursed so much. So the hospital may end up eating some of the costs because again, some snake bites. In this case, you'll see the crofab would be the antidote for a pit viper like that. Some patients I can give, maybe 10 vials at a minimum, right? So they got the full course where they got 4 vials up front, and then I gave them 3 maintenance doses of 2 vials each. 10 vials in total. That's one thing. One of the Eastern Diamondbacks, I can see using 20, 30, 40 vials potentially of antivenom. And again, these are probably like around $1,500, $1,600 a vial. So you're talking pretty expensive hospital stay. So in a lot of cases, you may find that the hospital ends up eating the cost. That's why a lot of times we'll do these things. If you ever hear like consignment in a hospital, it usually means they're expensive drugs we have on hand that we don't actually pay for until we use them. And so that's what we do with crofabs. That way we can keep enough on hand to actually manage these patients without having to eat a lot of that cost. But again, we're coming up on snakebite season, so you guys may see that coming up here pretty soon. Anyway, yes, crofab would be indicated because it's a pit viper, right? Tetanus vaccine would also be indicated because, again, you want to update that if the patient has an unknown status or if they have not received it within. What time frame for tetanus? 10 years, perfect. Rabies would not be appropriate. The snakes are not known for carrying rabies, unlike mongooses or mongoose. North American coral snake antivenom, also not appropriate for a pit viper, right? They're different enough. The venoms would not interact with one another. Good. Let's see. A patient taking zolpidem for sleep is at risk for all of the following except physical dependence, tolerance, daytime drowsiness, or seizure. Pretty confident? Are you walking away? I got this. Right on time, too. Perfect. So just cover these drugs, but knowing how their mechanism works, we should be able to identify this. Yep. So physical dependence, they're definitely at risk for physical dependence, right? These are controlled substances. They're made as such because of that. Tolerance, you're definitely going to develop tolerance. You may need to increase doses as time goes on as they get used to that drug being around. Daytime drowsiness is another common thing you're going to see with that, right? So normally, do you want your patient to start this on a Sunday night and have to go work on Monday? Not typically, right? Maybe over the weekend or something is a good time to try it out and see how it's going to affect them. But definitely, would they be at risk for seizures? Why not? How's it working? The GABA A receptor, right? So we know if they're agonists there, if they're opening up those GABA channels, guess what? Chloride's flowing in. That would actually be the same as giving a benzo. No one is going to develop a seizure because I'm giving them a benzo, right? Same principle goes with this. However, if they're on it chronically and I withdraw that all of a sudden, could they be at risk? Absolutely. Yeah. Withdrawal from benzos of any sort could be potentially causing seizure. Good. All right. So our winner is Brit Pet. Finally pulled it out in the very end. Fantastic. Who is not Brit Pet? I'd have to ask. Oh, they're not going to reveal themselves. Interesting. The mystery continues. How about right hand? Who's right hand? Fantastic. Good job. Your free answer is B. B. Let's go with B. That'll work. Fantastic. Any questions before I stop the recording? Anything at all? Congratulations, you made it through Pharm. Clin Pharm, I think, is probably going to be pretty. You guys will roll through that just fine. I think you guys are pretty well equipped for that. But yeah, anything else? Like, I'll see you guys around. Oh, so sweet. I'll do a lecture for. I mean, you'll still see me around. You can't get rid of me that easily. So, all right, I'll see you guys later.